Welcome again to the Infection Tube. Here in this video, we will discuss the updated WHO case definition regarding the current outbreak, covering how to identify cases, classify them as suspected, probable, or confirmed, and how to define and identify contacts. We will also look into the treatment plan. This is simply a protocol for identification and management of Mpox cases. First, you may ask, what is Mpox? What is its causative organism? And why is it called so? Mpox is a viral zoonotic infection caused by the Monkeypox virus, an orthopoxvirus in the same genus as variola, the causative agent of smallpox, and vaccinia viruses, the virus used in the smallpox vaccine. Mpox was previously referred to as monkeypox. It was first isolated in Denmark in the late 1950s from a colony of laboratory monkeys from Singapore that were going to be used for poliovirus research, hence the name monkeypox. There have been two distinct strains of the monkeypox virus, Clade I and Clade II. Clade II is less virulent and lacks several genes present in Clade I. More recently, each clade was found to have subclades, Clades 1A and 1B, and Clades 2A and 2B. This outbreak is likely due to a novel Clade I lineage, Clade Ib, linked to sustained human-to-human transmission. Now let's move on to the protocol of identification and management. According to WHO, when do we suspect a case? In other words, when do we say that a person is a suspected case of Mpox? A person is a suspected case if they have had contact with a probable or confirmed Mpox case within 21 days and develop one or more of the following. Fever, greater than or equal to 38.5 degrees Celsius. Headache, back pain, lymphadenopathy, myalgia, asthenia, or if a person presents with an unexplained acute skin rash, mucosal lesions, or lymphadenopathy, and for which the common causes of acute rash or skin lesions do not fully explain the clinical picture. The skin rash may include single or multiple lesions in the anogenital region or elsewhere on the body. Mucosal lesions may include single or multiple oral, conjunctival, urethral, penile, vaginal, or anorectal lesions. Anorectal lesions can also manifest as anorectal inflammation, which known as proctitis, pain, and/or bleeding. Do you know the common causes of acute rash or skin lesions? Yes, these include chickenpox, herpes zoster, measles, herpes simplex, bacterial skin infections, disseminated gonococcus infection, primary or secondary syphilis, chancroid, lymphogranuloma venereum, granuloma inguinale, molluscum contagiosum, allergic reactions, or any other locally relevant common causes of papular or vesicular rash. Please note, if suspicion of Mpox infection is high due to either history and/or clinical presentation or possible exposure to a case, it is not necessary to obtain negative laboratory results for these listed common causes of rash illness to classify a case as suspected. So, once you've defined a case as suspected, what should you do? Notify health authorities. Home or hospital isolation according to severity. Implement infection control measures. Conduct a PCR test for confirmation. Now, when do you define a person as a probable case of Mpox? A probable case is a person presenting with an unexplained acute skin rash, mucosal lesions, or lymphadenopathy, and one or more of the following. Epidemiological link or direct physical, sexual contact or indirect contact with a probable or confirmed case of Mpox. Has had multiple casual sexual partners. A positive test for orthopoxvirus infection in the 21 days before symptom onset. You may ask, what is an epidemiological link and what is the difference between it and direct contact? An epidemiological link means face-to-face exposure, including health workers without eye and respiratory protection. Direct contact refers to contact with skin or skin lesions, while indirect contact means contact with contaminated materials such as clothing, bedding, or utensils. Now that you've defined your case as probable, what should you do? Notify the authorities. Hospitalize the patient in an isolated room. Implement infection control measures. Conduct PCR for confirmation. AS. Identify contacts. Do you know how to collect samples for PCR? For lesion specimen collection, collect a swab of vesicular or pustular fluid or a scab or crust from 2 separate lesions using separate swabs. Ensure that vesicular or pustular samples are collected on the tip of the sterile swab, with exudate visible on the swab itself. Vigorously rub the bottom of each lesion to include cellular material, unroofing the lesion if necessary. So, when do we say a case is confirmed? A confirmed case occurs when laboratory tests detect unique sequences of monkeypox virus DNA by real-time PCR and/or sequencing. What about discarded cases? A suspected or probable case is discarded if laboratory testing of lesion fluid, skin specimens, or crusts by PCR and/or sequencing is negative for monkeypox virus. And what are contacts? A contact is a person exposed to an infected individual during their infectious period, that is the period beginning with the onset of the index case's first symptoms and ending when all scabs have fallen off. Now, how do we treat confirmed cases of Mpox? For mild illness without complications, hospital isolation and infection control measures, supportive therapy, and contact identification. Protect skin and mucous membranes by keeping them clean and using light dressings for extensive lesions. Consult an ophthalmologist for conjunctivitis. Provide rehydration therapy, ORS or IV fluids, antipyretics, paracetamol for fever, baths and antihistamines for itching, and pain relief, as paracetamol. For severe cases, isolation in the ICU, management of complications, and antiviral therapy, if indicated, are necessary. Examples of complications include secondary bacterial infections like boils or abscesses, which require antiseptic cleaning and empirical antibiotics. Examples: clindamycin, cephalosporins, or amoxicillin, clavulanic acid. Other complications may include bronchopneumonia, encephalitis, or keratitis, requiring ophthalmological consultation. When we come to antiviral therapy, you must know 2 things. First, what are the indications for antiviral therapy? Second, what are the types of antiviral agents, their doses, and the duration of treatment? 1. Indications for antiviral therapy: patients with severe or life-threatening manifestations of Mpox at presentation, or patients at risk for severe disseminated disease regardless of the severity of Mpox at presentation as severely immunocompromised individuals, persons under 18 years of age, pregnant or lactating women, patients with active skin conditions that place them at higher risk for disseminated infection, such as eczema, burns, impetigo, active varicella-zoster virus infection, and psoriasis. 2. Types of antiviral agents. The main antiviral agents are tecovirimat, brincidofovir, cidofovir. Tecovirimat is the best choice, and cidofovir given intravenously once weekly for 2 weeks, accompanied by oral probenecid and IV hydration with 0.9% normal saline. To stay informed and updated with more valuable information like this, don't forget to subscribe, share this video, and hit the notification bell for updates from the infection tube.